So this is part 4 excuse me, of the osteoporosis series, and we're going to pick up on the discussion of starting, stopping, what is our endpoint when we talk about treatment. And so to answer these questions, the ASBMR convened a task force, and this was published just a year or so ago by Bob Adler on the issue of long-term therapy with bisphosphonates. And it's a pretty useful algorithm. You have a postmenopausal woman. She's been treated with oral 5 years or more, or IV 3 years or more. And that would be the time that you reassess. And you would ask or find out that there has or has not been hip, spine, or other osteoporotic fractures before or during therapy. So trying to get a sense of what risk, what risk this patient was or is at. And if the answer is yes, the answer is there have been previous or multiple fractures. So you would reassess benefits and risk, perhaps continue bisphosphonate, or change. But the idea would be to continue therapy and to reassess in a few years. So you'd go beyond the usual, perhaps the stopping point. If there haven't been osteoporotic fractures and the T-score is less than -2.5, or the patient is still at high fracture risk, the answer to that point, if it's no, you would consider a drug holiday and reassess. If the answer is yes, she's still at high risk based on the T-score and other risk factors, then you would reassess benefits risk, continue perhaps up to 10 years, or change to alternative therapy and reassess. So that's reasonable, logical, and it perhaps takes into account the fact that there is long-term benefits to using bisphosphonates, but then there are issues that we've talked about before that might give you some pause.
Dr. Sorry. So if we start a drug holiday, it's for 2 or 3 years?
Yeah. This is what we say fungible. The word is, I don't know what the Italian is, fungible. Changeable. I use bone markers, and obviously the clinical situation, bone density, to know whether you're going to go even after 1 year. You might reassess. So I don't know why they put 2 years in. But some of the treatments, like for example risedronate, it's a fairly short-lived bisphosphonate, and different from zoledronic acid or alendronate, there may be evidence for, let's say, a return of bone turnover within a year after risedronate. So there may be a situation where you'd restart after 1 year. In the case of zoledronic acid, I have some patients who have gone for 2 and 3 years checking bone density and bone turnover markers, and they've been stable. So my feeling has been, well, they're not getting, no signs that they're getting worse. We'll keep the drug holiday on. So it's really quite individualized. It kind of depends on how you like to think about this and how you regard whatever the long-term risks are, and there are, versus the long-term benefits. Okay, so I'm going to give you 5 examples that speak to when you stop, when you not, do you change, with the concept of the treatment to target. And the notion being, if you can get them to a T-score of -2.5 or greater, that would be good. So this is a 72-year-old woman with no known fractures, normal vertebral fracture assessment. Mother had a hip fracture, and her femoral neck T-score is -2.7. The current thinking with this kind of patient is that first line would be a generic oral bisphosphonate. That's what the payers want, and you're going to be hard-pressed to argue with them. And if you wanted to think about treatment to target, what are the chances that you can get to -2.5 or better with a generic bisphosphonate? The answer is pretty good. So the current state of the standard approach is the same as what you would like in terms of your target. All right, here's patient B. This is an 81-year-old man with a prevalent vertebral fracture. We don't know how long. And his femoral neck T-score is really low, -3.8. The first-line agent is oral bisphosphonate. That's what the payers are going to want you to start with. If you want to get to a target of -2.5, you're never going to get there with a bisphosphonate. I don't think. I mean, from -3.8 to -2.5, you're going to have to increase bone density by 13 to 15%. So the treatment to target idea would be to start with an agent more likely to get to where you want to go, and that would push you into the direction of an osteoanabolic or Denosumab. So there would be a little bit of a difference here. Your view might be to be more proactive than the standard approach to therapy. This person is by definition at high risk, very low bone density, a prevalent vertebral fracture. And you can certainly argue, you might have to make some phone calls, you may have to fill out forms. If you're your patient's advocate, as you are, you can, I think you can, I can get to the drugs I want to use. All right, patient C. 67-year-old woman with baseline total hip T-score -2.5 is treated with alendronate for 5 years, and now her T-score is -1.9. It's pretty good. She's had no fracture either before or during. The current paradigm would be to consider a drug holiday according to ASBMR task force suggestions. And yeah, I would agree with that. You've gotten to a nice level. She's done well, no interim issues. So she's gotten to her target. And a drug holiday makes sense in a patient like this. This is patient D, 84-year-old woman whose baseline total hip T-score is -3.7. After 5 years of alendronate, her T-score is now -3.3. She has no fracture. So she's done well, but she's still awfully low. And so the ASBMR would say, well, consider continuing alendronate, and you can do that. But if you want to get to -2.5, you're going to think about switching. And the idea of a more robust, the word is robust, so you might consider switching to Denosumab or an osteoanabolic in this case.
Sorry, because probably I should have known this, but what is your expectation for this patient starting with -3.7 with 5 years of alendronate? Is that what you expect normally?
Yeah, everybody's different, but that's a, if you want to translate that in terms of a percentage, probably 4 to 6%. Some people, this is total hip. That's pretty good. Everybody's different, but that's within the ballpark of what you would expect with alendronate at the total hip. Maybe a little bit more in the lumbar spine, but not a bad response. Not a bad response. Okay, patient D. E. 78-year-old woman with a baseline femoral neck T-score of -2.8. After 5 years of alendronate, she's now at -2.2, 6% or so. She tells you she fell and broke her shoulder in a fall 6 months ago. Well, the thought would be, well, she's had 5 years of alendronate and she's done very well by T-score. But I worry about the fracture. We don't know too much about the circumstances except that she fell and she had. So I think the idea of treating to target, you've got to now modify that to think about what happened to her. Yeah, she's reached a target, but she had an interim event. So in this case, so many of us would continue alendronate. I don't know that I would continue alendronate. I probably would switch. This gets into the question of, is this drug failure or not? She did well, bone density went up, but she had a fracture. So you may think the drug is working, and you may tell the patient, nothing's perfect. Even these drugs are not perfect, and people do have fractures on drug. Who knows, you may have had 2 fractures. And she's going to tell you, I had a fracture, and you put me on this great drug, I want another drug. That's perfectly reasonable. And you can define drug failure based on having had a fragility fracture during treatment, even though theoretically you could argue the opposite. Now let me get back to Denosumab, because this whole idea of treatment to target was based on the fact that with a drug, you can get to a point where you can say, gee, I've gotten to where I want to go. But a couple of points about adverse events with Denosumab. The skin, and specifically with regard to eczema, there was a clear imbalance with those who were on Denosumab versus those who were on placebo. And so this kind of skin reaction, someone who's predisposed to eczema, what have you, that seems to be possible. Overall infections were not different. And that's worthy of note because, again, your patients will have read the package insert, and the infections are all over the package insert. And the fact that the rank ligand system is involved in T cell function theoretically could predispose patients to infections. It seems like the adult whose immune system is pretty well developed isn't seeing very much in the way of infections. We would be much more concerned in someone who's developing their immune system. But when we think about drugs for osteoporosis, most of the people we're talking about have well-developed immune system. If you have an immunodeficiency situation, that may be a little different. Now, getting back to skin, or continuing with skin, cellulitis was the big imbalance here, with 12 cases with Denosumab and only 1. And very interestingly, half of these cases of erysipelas were erysipelas, and they came from a site in Mexico City, one of the investigative sites. And that's interesting because, first of all, adults typically don't get beta strep infections of the skin. That's a childhood thing. And secondly, there was never any bacteriological proof that this was beta strep. So I don't know whether it really was erysipelas. But whatever, cellulitis was called, and there was an imbalance. Now this was the first 3 years of the study. We're going to see more later experience with this. This table is in the package insert. And this isn't adverse events, this is adverse reactions. It's a very different definition by the FDA. An adverse reaction is defined as a numerical imbalance of anything that occurs more often in the drug arm than the placebo arm. If the event occurs more frequently in the placebo arm than the drug arm, it's not recorded. There are no statistics to this. And the bottom of that package insert, which you can't read because it's not there, says the most common adverse reaction to Denosumab was back pain. All right, well, look at this. True. 1,347 examples of back pain. That far exceeded the next in the line. But look at the number of cases of back pain in the placebo group. 1,340. Now, your patients are not as well versed in statistics as you do. And they'll say, doctor, this drug is going to cause back pain. You have to remind them, no, it was basically the same as the placebo group. I had a patient who said to me, "Doctor, I can't take this drug. Why not?" She says, "Because it causes shingles." She said, "Didn't you read the package insert?" All right, let's go to shingles. Yes, 79 cases in Prolia, 72 cases with placebo. Can't be significant. Yet, there is that information that can be very misleading, and you need to know this, because you can then tell your patient, no, this drug doesn't cause shingles. So the infection story is listed here. Serious infections leading to hospitalization were, yes, reported more frequently with Prolia. Skin infections were seen more commonly. And there were a smattering of other infections. Urinary tract, ear, there was one or two cases of endocarditis, but there was no increased incidence of opportunistic infections.
What's interesting is with the increased risk of cellulitis and eczema, in the Freedom extension data, there was not an increase.
Hold it.
So I don't know.
Thank you, Tanya. You're anticipating. Some of you see my slides. Thank you. We're going to get there. You're absolutely right. The extension did not confirm what I just told you. That's why it brings into question even more whether that 3-year experience was really teaching us very much. But the skin was a site of attention. By the way, the infections in the skin were not specific to the site of the injection of the Denosumab. And here is exactly on cue the more recent, that is not recent, but the more extended information about these events. So here we've talked about the skin, eczema, infection, cellulitis, and here is the 4 to 5 year data, and it shows that even 4 to 5 years out, there is less, in fact, very much less in all these cases. So even the 10-year data are similar to what I just showed you with the 4 to 5. So this imbalance in infection, the only thing that has sort of stayed true is this imbalance with eczema. But cellulitis has gone away as an issue. So, bless you. And I have never seen a case of cellulitis. And we now have how many years of experience with Denosumab? We have 8 years of experience since it was approved in June of 2010. And it's just not happening. We're not seeing it. So again, this is just a, this is the renal point. This was a sub-analysis. And this was one of the things that led to the point that we can use Denosumab in individuals who have rather modest renal compromise. And it did not, the efficacy did not seem to be a function of the level of creatinine clearance. The drug seemed to work at all levels. So we now know and say we can use this drug, very different from the bisphosphonates, in subjects with renal failure. You don't have to adjust the dose, but we always are careful, particularly in patients, we locked her out. Carmen, we locked you out. But you need to be very careful, always, but even particularly so. In patients whose creatinine clearance is under 30, I would say make sure the serum calcium is normal. Make sure the 25-hydroxy is over 30 nanograms per ml. Because if they aren't normal, this is the group that can become symptomatically hypocalcemic after injection of Denosumab. So baseline laboratory values, anyone starting DMAB, make sure the calcium is normal, make sure the 25D. And then we talked about this last week. I've added this to my discussion. Be aware of patients who have had previous neck surgery, possibly subclinical hypopara, as I told you that case last week. And I would measure PTH in all patients who have had prior neck surgery. And let's say the calcium's normal at 9.2. But if the PTH is under 20, I would wonder, worry, be concerned that this patient could have subclinical hypopara. This hasn't actually been recognized as an entity, but I am sure subclinical hypoparathyroidism exists. Just as we have described normal calcemic hyperparathyroidism, there is this entity of normal calcemic hypoparathyroidism. And actually, Natalie was the lead author, Dr. Cusano, in our survey of patients, this two large epidemiological cohorts, the Dallas Heart Study and Mr. Oz, where we identified some patients with subclinical hypopara. So again, be aware. ONJ has been reported in the Freedom trial. 2 patients had taken Denosumab continuously, but 2 were in the placebo group for the first 3 years, and they developed it after they started on DMAB. And there have been rare atypical fractures described. So yeah, we're dealing with whatever. This is not these complications of ONJ and atypical fractures. That's not unique to the bisphosphonate class. Yeah.
Sorry, Dr. B, I have a question. I had a patient who we gave 1 injection of Denosumab to, and she had subsequently seen her orthopedic surgeon and was described to have an impending atypical femoral fracture. So I was just wondering what your comments were and what you would do in that situation.
Yeah. 1 dose of DMAB.
Yeah.
Was she symptomatic? Did she have thigh pain?
She did. She had thigh pain.
And the findings they're seeing are bilateral?
No, it was unilateral.
Unilateral.
Yeah.
And is she Asian?
She's from Korea, and she had that very typical, like she had, she's
Asian.
Yeah, she's Asian.
Yeah.
Very thin with the small legs. Yeah.
And I would, yes, this is tough. I would really look carefully at the x-rays. And the impending, is there a cortical discontinuity?
That's what they said. That's what the orthopedic
All right, I would,
said.
so
Yeah.
that's fine. Make sure that you agree.
Okay.
If there is a discontinuity, then you're stuck in a way. You can't say no, it doesn't exist. But you do worry about, people get atypical fractures, or let's say subtrochanteric fractures, is a fracture that occurs in osteoporosis. 9% of all so-called hip fractures, let's say they're hip fractures, occur below the trochanter. There are then these very specific characteristics of the subtrochanteric fracture that kind of defines it in the context what we're talking about, the long-term administration of these powerful antiresorptives. She's had 1 dose. So you can't blame Denosumab. Is this something about her? Maybe she is predisposed to a subtroch fracture because she would have had a subtroch fracture even if you had never given her the dose. So that's the part of the discussion. But if you see cortical discontinuity and if you see spiking, you really can't continue with Denosumab. And if you decided to use Denosumab for good reason, postmenopausal women at high risk for fracture, this is the kind of patient who you could probably argue to use an osteoanabolic. So I would, you can't take it lightly, but certainly I don't think you can blame Denosumab for that. Okay, now we're going to talk about, and you'll notice that I've changed the wording of anabolic therapy to osteoanabolic, only because the word anabolic has a connotation these days in the sports world. You know, performance-enhancing drugs, anabolics. And we're not talking about those drugs. We're talking about osteoanabolic drugs, those that are specifically helpful for the skeleton. So we've seen these 2 ladies. You certainly saw the late Pope and this lady. And the question is, how did we get to this conceptual leap from PTH as a bad actor when present in excess to PTH as a therapeutic? An interesting question. And we're going to address that. the antiresorptives, as good as they are, do not transform the skeleton from this osteoporotic picture to this less osteoporotic picture, and certainly not to a normal skeleton. And when I give lectures, I then say to large groups, I say, now some of you who still dare to dream, is it possible that you can restore the microarchitectural deficit in osteoporosis to normal? And that's kind of the holy grail. Can we get there? We're not there yet. I'm not saying we are, but we're getting there. So how about PTH? If you give PTH to rats, they will gain an enormous amount of bone. They will sclerose their marrows. They will develop extramedullary hematopoiesis. So we've known that for years. We've known that in hyperparathyroidism, that differential effect of PTH by bone density to be detrimental to cortical bone, but not so detrimental to trabecular bone. Now, we've revised this thinking because of what we know about HRPQCT. But just the densitometric distinction between PTH being bad for cortical bone and not so bad for trabecular bone, plus work by John Parsons in the early 70s that began this discussion about maybe under certain circumstances this bad actor could be beneficial. A number of individuals have contributed conceptually over a good 20, 30 years to this idea. And these authors, John Parsons, Jonathan Reeve, John Potts, David Slovic, Bob Neer, Tony Hodgman from UT, and Harold Dobnik, and many others have demonstrated, and this is a summary, that under certain circumstances, PTH can be anabolic. When it was shown to be anabolic, Andy Stewart had an editorial in JCM years ago. It was entitled Borrowing from Peter to Pay Paul. The idea was that this was a cortical steal, that PTH was taking, resorbing cortical bone and enhancing trabecular bone. In the early days, it was thought that you needed an active vitamin D analog or an antiresorptive to mitigate this catabolic effect at cortical bone. The antiresorptive, obviously, would block bone resorption and allow PTH to be more bone forming. And the idea of the vitamin D analog was to enhance calcium absorption. So you provide more calcium and kind of stack the deck in favor of getting calcium into bone. But Bob Neer, in the famous paper published in the New England Journal in 2001, he used teriparatide alone, without an antiresorptive and without active vitamin D. And he showed pretty profound effects. But let's get back to the theory about under what circumstances would PTH be good for bone. This work goes way back. Again, Harold Dobnik and Russ Turner gave PTH to rats under two different conditions. The so-called intermittent, which was 1 hour a day, or 24/7. And then looking at a histomorphometric index for osteoblast or osteoclast activity, he showed that the 1 hour per day group showed evidence for osteoblast stimulation, but not the continuous. On the other hand, when the drug was infused 24/7, there was no evidence for osteoblast, but the osteoclast was more active. And that led to this notion that continuous, relatively high-dose PTH would be catabolic for bone, but daily or intermittent low-dose PTH would be anabolic for bone. Further, the mechanism by which PTH might be anabolic for bone feeds into the two major pathways of parathyroid hormone action. I mentioned the other day that PTH needs rank ligand to work through this pathway, including cyclic AMP, to be catabolic for bone. We also know that PTH has anti-sclerostin actions to relieve the regulatory effect of sclerostin and stimulate Wnt signaling, which is the beta-catenin active osteoanabolic pathway. So we know that PTH can work on both pathways, and does. But under conditions of intermittent administration, this pathway is shifted to the left. And I suggested also when Denosumab is around, you're blocking that pathway by another mechanism. So the thinking is that low-dose, intermittent administration with pulsatility kinetics, such that PTH is rapidly increasing in the circulation and presumably at target tissues, and then lost. Those rapid pulsatility kinetics leads to a differential effect of PTH to be more anabolic than catabolic. Bob Lindsay showed this many, many years ago using the bone formation marker osteocalcin and the resorption marker N-telepeptide. Tracking this over time, he showed that osteocalcin goes up first, followed by the increase in the N-telepeptide. And there is a short period of time, 1 or 2 months, when this differential is really great. And this is a period when PTH seems to be maximally anabolic. Now, beyond bone marker data, we have bone biopsy data. And this is from David Dempster, who has done quadruple label tetracycline. Did he talk to you about quadruple label? Where you administer 2 doses of tetracycline, you get 2 labels, and then you don't biopsy, though. Let a couple of months go by, and then you do another double label, and then you do the biopsy. So the first set of double labels is the first administration of tetracycline, and the second is the second. And the distance between these 2 labels is a measure of bone formation. And what David showed was that under the influence of teriparatide, these double labels are particularly the second, because that's after teriparatide was administered, is extending throughout the whole surface of bone, while the control is very limited. The idea that this double label, the second double label, is extending through the entire surface of bone brought up the idea that maybe PTH wasn't only stimulating bone remodeling, because if it was, it wouldn't be diffusely labeling the entire bone. So the concept that you need to have a bone remodeling unit, starting with bone resorption and then bone formation, was not viable when it came to the early effects of PTH. Rather, it seemed that under these circumstances, maybe PTH is directly stimulating bone formation on quiescent surfaces. That is called bone modeling, and that's what we see in children. Children grow bone on quiet surfaces. Adults are not supposed to grow bone on quiet surfaces, but now we have some evidence that it does under certain circumstances like this. So the model that I've proposed is that there is the initial effect to stimulate bone formation. And the early increase in bone formation I mentioned both by markers and by bone biopsy, followed by an increase in bone remodeling as described by a subsequent increase in resorption, giving us a time period when the anabolic effects of PTH are maximal. And we have said that this is a window, an anabolic window, or an osteoanabolic window. With regard to the initial actions of PTH, it would appear that this is modeling based, while the secondary effect, but ultimately the predominant effect, would be remodeling. Remodeling based bone formation would argue that there's more bone formed than lost. So it's remodeling, but it's positive in positive balance. So what David has suggested is that we've got three things to deal with: remodeling based bone formation, modeling based bone formation, and then third concept, which he calls overflow modeling based bone formation. And let me describe what David has recently published. I don't even think it's in paper form, but it's in e-print. Remodeling based formation is where you get the usual scalloping of the osteoclasts having eaten a piece of bone, and you get bone formed, collagen matrix bone formed, and you're in positive balance. So there is more bone at the end of this cycle than there was before. That's called remodeling based bone formation. And you can see this histologically by seeing this scalloped line underneath the surface of bone being formed. Modeling based bone formation is different. You're basically forming bone on quiescent surfaces, and you see no scalloping. It's a smooth cement line. There's just nothing there except new bone. And then what David has said is overflow modeling based bone formation. That is, you get the scalloping, you get the bone formed exuberantly, but there's so much bone being formed it spills over outside this lacuna, and it appears to be bone on quiescent surfaces, but it's actually spillover from the remodeling space. And you can actually see these three forms in this diagram, or the histological evidence that David has presented. Remodeling based bone formation, you see the tetracycline on the left is exactly coincident with the scalloping you can see on the right. Modeling based formation, you see no scalloping on the left, you just see bone formation on the right. And then the spillover is that the tetracycline spills over on the entire surface that you're seeing, while the scallop line is only in a limited portion. So you can actually see modeling based formation, remodeling based, and then this overflow. And we think that these osteoanabolics work in all three ways. If you wanted to quantitate it, it's probably 30% is pure modeling based, and about 70% is remodeling based or spillover. But the initial effects are probably pure modeling. Okay, is that okay? Give you a sense of how these drugs work? So we have two drugs to talk about, Teriparatide and Abaloparatide. And you've seen this so many times. Just to reiterate, we're talking about Teriparatide as the therapeutic for osteoporosis. We are not talking about intact PTH 1 to 84 as a therapeutic for osteoporosis. We're talking about Teriparatide. And this study by Bob Neer was very well designed. It was supposed to be a 3-year study. Relatively small study of only 1,637 subjects. There were 3 arms, placebo, 20 micrograms, 40 micrograms of teriparatide administered subcutaneously every day. The endpoints were vert, non-vert fractures, bone density, bone markers, and in contrast to the plan, to this be a 36-month study, the median duration of treatment was only 21 months. The study was stopped. The study was stopped because the simultaneous rat toxicity studies showed unequivocally that this molecule was causing osteosarcoma in Sprague-Dawley, Fisher 340, not Sprague-Dawley, Fisher 344 rats. Subsequently, other rats were shown to develop this bone cancer. 50% of female and male rats developed the osteosarcoma. So it seemed like this drug was dead. Right? Dead. And I remember having discussions with some people in the company, and I said, are you going to evaluate the data? Yeah, but the drug's dead. Well, suppose you find great efficacy. Yeah, but the drug's dead. And the question was for the company, how great did the efficacy have to be to deal with this animal toxicity? There were monkey studies being done also, and the monkeys were not showing any effects. In fact, to date, there has never been a monkey, to my knowledge, they use cynomolgus monkeys. To my knowledge, there has never been a monkey subjected to the toxic doses of PTH that are required for toxicity studies. A monkey has never developed osteosarcoma with this PTH or any PTH. And most of us believe that we're more closely related with regard to our bone metabolism, I won't say any other relations, to the monkey than the rat. Well, what are the data? Here are the data. 20 microgram dose, also the 40 microgram dose, but forget the 40 microgram dose because there were greater incidences of hypercalcemia and other things with no real difference in efficacy. That's why the 20 microgram dose became the dose. 65% relative risk reduction of new vertebral fractures, 53% relative risk reduction of non-vertebral fractures. We have no hip data because the study was awfully small. I think there were 4 cases in the placebo arm, 2 cases in the treatment arm, but the data were too sparse to do any kind of statistics. And over the years, the drug has been shown to also be effective at sort of any degree of involvement as you define it as previous fragility fractures. It is very efficacious in glucocorticoid-induced osteoporosis and also efficacious in male osteoporosis. Getting back to what we would like to see with an anabolic agent, this is from David Dempster again, showing by bone biopsy, looking at one index connectivity density, but other parameters, looking at before and after, you begin to see what is the potential of this drug. That it can restore microstructure of the trabecular compartment, and also you appreciate that the cortical envelope looks better as well. So, yeah, this drug seems to do a lot. Not just improve bone density, not just reduce vertebral and non-vertebral fracture, but also to help to restore the microstructure of bone. Very recently, in fact, just a couple of months ago, a head-to-head study was done comparing teriparatide with resindronate. And it was the first head-to-head clinical trial with incident fractures, not bone density, but incident fractures as a primary outcome. Very well designed, double-blind, placebo-controlled. These numbers of women, they had pretty advanced osteoporosis, 2-year study, and the outcome variable was new radiographic vertebral fractures. And as you can see here, the blue is teriparatide, 12 months, 24 months, and you can see that there are fewer fractures in the teriparatide arm than the risedronate arm, with a relative risk reduction of about 0.5, 0.52, 0.44, highly significant. So comparing a head-to-head, both very efficacious agents, you see a clear advantage in this study of teriparatide over this bisphosphonate. And looking at the Kaplan-Meier to first clinical fracture or to first non-vertebral fracture, you see how the curves separate. They begin to separate as early as 6 months into this trial. So within 6 months, you're beginning to see, although you have to be careful about the statistics on a Kaplan-Meier, but you're beginning to see a separation, the early efficacy of teriparatide versus efficacy with risedronate. We don't have a placebo here, so we can't compare placebo, but presumed efficacy of risedronate as well if we had a placebo control, but we didn't. So teriparatide was significantly more efficacious than risedronate at preventing vertebral fractures and clinical fractures, but not non-vertebral fractures in patients at high risk. Now let me get back to the issue of safety. This is a black box drug. So the FDA has made it clear that they are concerned about this animal toxicity. And a lot of my patients will say, "Doctor, I can't take this drug. It causes cancer." You need to know this. If you don't hear this from the patient, you have to bring it up. It's your responsibility to discuss the issue of osteosarcoma. The drug teriparatide, which was approved on November 26, 2002, is almost 16 years old. And over these 16 years, there have been no oncogenic signals at all. What would be a signal? Well, cases of osteosarcoma. There have been 3, 4, maybe 5 cases of osteosarcoma among patients who have been treated with teriparatide, with a base of well over 2 million people who have gotten this drug worldwide. If you know the incidence of osteosarcoma in the adult population, it's like 1 in 250,000. So statistically, there should be, at random, at least 8 to 10 cases coincidentally observed among a cohort of 2 million people, whether they got drug or not. But we're seeing fewer, not even the same as you would expect, just random alone. And there are other points that make it problematical as to whether we are dealing with a linkage here. The rat, as I mentioned, I believe, is a growing animal until it dies, never stops growing. Its epiphyses are always open. So it's more a modeling-based animal than a remodeling-based animal. When the rat is exposed to an anabolic stimulus, it can't stop, like it scleroses its marrow. The human, or the monkey, have built-in controls. You cannot overstimulate the skeleton easily with teriparatide. And those markers that go up, you notice they come down. They go up and they come down. And over time, if you use teriparatide long enough, maybe 3 years, maybe 4 years, you're not allowed to do that, bone markers will go back to baseline because the body will control that anabolic effect with remodeling and quiet everything down. And I think that's one of the major reasons why we don't see osteosarcoma, because the human skeleton doesn't allow itself to be overstimulated. Nevertheless, it's a black box drug. It's extremely unusual for the FDA to take away a black box warning. Very, very unusual. And we're going to learn that the next drug, Abaloparatide, also has a black box warning. All right, knowing that, there are patients for whom we will not use a PTH. We do not use it for in children who have open epiphyses. Obviously, they have open epiphyses if they're children. If they have a history of osteosarcoma, this is a Paget's disease, and this is the big one. Exposure RT to bone, which happens a lot, of course, in someone who's being treated with RT for breast cancer. That's going to include the ribs. So that's a contraindication to the use of teriparatide. Obviously, someone who has hypercalcemia, you're not going to use teriparatide. Pregnancy, not going to use it. Metastatic disease, particularly the diseases associated with osteoblastic metastases, some breast cancers, some prostate cancers. So, yes, we know about the toxicity. No, I don't think there's a link, but we have to be careful in particular groups who are at high risk for osteosarcoma by virtue of what they have. Now, another anabolic has been developed, and that anabolic is called Abaloparatide. This schematic really nicely describes Abalo versus PTHRP versus teriparatide. This is just obviously a cartoon of the 34 amino acid sequence of teriparatide, and it's all shown in green. PTHRP, as we talked about last week, has homology to teriparatide in the green residues, are similar, are identical to teriparatide. And the white residues are different, but they're kind of conserved, so they kind of behave the same way. When you get beyond residue 15 or so, PTHRP diverges a lot from teriparatide, and there are only a couple of amino acids that are shared. Now, abaloparatide was developed with the idea that a more potent anabolic could be developed. If you substituted some of these amino acids in PTHRP with others. Not that Gary Hattersley knew what those residues would be to make a better PTHRP or better PTH, but that if you just empirically made a lot of molecules, so they made about 200 of these molecules, and they ran them through a high throughput design, and this molecule fell out as the most anabolic. The yellow cassettes are the amino acids that are different from PTHRP. And you can see the homology. PTHRP and abaloparatide are identical out to residue 22. And then from residue 22 to 34, there's quite a good divergence, and there's only 38% homology with PTHRP. So that was the idea, to make a more potent osteoanabolic. Now, there was another theory to this. How do you make a better anabolic? Well, why is this molecule more anabolic, or allegedly more anabolic than teriparatide? If it were to bind more selectively to the configuration of the PTHRP receptor that is locked into the anabolic pathway, it would be more anabolic. There is one PTH receptor in the periphery, and it binds PTH, it binds PTHRP, it binds abaloparatide, it binds any PTH. The configuration on the left is known as RG, and the configuration on the right is known as R0. RG stands for G protein. And this form of the PTHRP receptor is a very evanescent interaction with the ligand. When I say evanescent, I mean it's a very quick hit. And I don't know what quick means, a microsecond, a nanosecond, a picosecond. But the ligand hits this receptor and immediately bounces off. In contrast, the R0 is the longer-lived interaction between the PTH ligand and the receptor. You would like, if you buy this idea, your potent anabolic to have preferential affinity for the RG because, again, short, intermittent, low-dose administration unmasks the anabolic properties of PTH. Well, this doesn't show that. This shows that teriparatide and abaloparatide have equivalent affinities for that transient state of the receptor. But when you come to the long-lived configuration, abaloparatide has poor affinity, very poor affinity. So if you then take the ratio of the various affinities, abaloparatide is going to have relatively greater affinity than teriparatide. And it turns out it's 1,600-fold, the fold greater affinity of abalo for this transient state of the receptor versus the prolonged state of the receptor. The fold difference is 1,600-fold versus a 3-fold difference with teriparatide. Okay, so that seems to be the case. And now translating this, we have abalo on the left, we have teriparatide on the right, and we have a more or less equivalent affinity of teriparatide for these two configurations. But for abalo, you can see there's just a little tiny line going to the R0, and most of it is going to interact with the RG. This is going to lead to a much steeper transient pulse of the signal, cyclic AMP, versus a longer live signal with the R0. And again, this will lead to a greater effect on osteoblasts with abalo as compared to teriparatide. So this is, Donovan actually came up with this. We actually, this is in press. We haven't yet been published, but it's kind of neat because it helps to explain the difference by a mechanism between abaloparatide and teriparatide. Okay, so the study is shown here. It was called ACTIVE, and a study of 2,500 postmenopausal women, international, double-blind, placebo-controlled. The design of the study was to be 18 months, and the inclusion criteria included a t-score of less than minus 2.5, and many of them had fractures as well. The design is shown here. 18 months, double-blinded was placebo versus abaloparatide at 80 micrograms versus open-label teriparatide at 20 micrograms. Why was teriparatide open-label? Because there was no way of masking the cartridge that we use for teriparatide. And they didn't make, so it was logistically not possible. They could blind this because they had a cartridge, their cartridge was abaloparatide, and they put in vehicle instead of the drug. So this was blinded, but this was open label. 18 months with a plan for an extension at the get-go. So this wasn't just an afterthought, let's switch everybody to alendronate. No. The plan was 18 months of treatment, then this arm goes away, no teriparatide after 18 months, but these two arms get switched to alendronate. Primary endpoint analysis at 6 months and exploratory endpoint analysis after 24 months of alendronate. It's open label at this point because everybody's on alendronate. But it's still blinded in the sense that nobody still knows what the original assignment was. So the people who are on placebo injection are getting alendronate. The people who are getting abalo injection are on alendronate. But nobody knows what the original assignment was until after the 2 years of alendronate. Okay? So here are the bone marker data, which are really kind of interesting. The blue is teriparatide, the orange is abalo, and the gray is placebo. And as you might expect, what you see is an initial burst of a bone formation marker, P1NP, for both abalo and teriparatide. And by the way, there is a greater, apparently, look at the standard deviation, it's really broad, but apparently a somewhat a greater stimulation with P1 with teriparatide. And the CTX marker, it goes up later with both ligands. The CTX rises much more slowly and not so much in the abalo arm versus the teriparatide. Very interesting, and this is kind of the idea, that the abaloparatide drug would be stimulating bone formation to a greater extent than it would be stimulating bone resorption. And this idea can be parlayed into my cartoon. If bone formation markers are the same, more or less, but bone resorption is stimulated to a lesser degree, you're creating a wider anabolic window with this drug that we are talking about. So in terms of bone density, not much of a difference at the lumbar spine between the two drugs. In terms of new vertebral fractures, not too much difference between the two drugs and placebo, both showing marked reductions in relative risk, 86% to 80%. But when it comes to non-vertebral sites, the hip, total hip and femoral neck bone density, the abaloparatide, looking at the orange, looks to show an increase a little bit earlier and a little bit more than the increase in bone density at these two hip sites with teriparatide. The non-vertebral fracture data are shown here. Non-vertebral fracture up top, clinical fracture here. And there is a significant reduction with abaloparatide compared to placebo. And you have to be careful with the teriparatide arm because since this is open label, it's not fair to infer, although there wasn't statistical significance, to say that teriparatide didn't. And we know from the Bob Neer study, clearly teriparatide does reduce non-vertebral fractures. So I would not pay too much attention to the apparent lack of effect of teriparatide. But clearly, abaloparatide is reducing non-vertebral fractures and clinical fractures. And looking back, again, another way of looking at the non-verts is this Kaplan-Meier. This is abaloparatide. This is teriparatide. And this is placebo. And if you go back to the Neer study, the separation between placebo and teriparatide occurred right about here, around a year, just around here, which is exactly what you're seeing here in this study. While the abaloparatide seems to separate itself earlier than either teriparatide or from teriparatide and placebo, and clearly is at the end significantly lower than the placebo. The study also looked at major osteoporotic fractures, not just the vertebral and the non-vert as a group, but the major osteoporotic fractures were defined as high or low trauma, clinical fractures, upper arm, forearm, hip, shoulder, and or spine, all put together. And relative to placebo, abaloparatide had a 70% reduction, and versus teriparatide, apparently a greater difference teriparatide versus placebo, to the extent that you can be confident there wasn't a major reduction. And looking at the intention to treat population, the reduction in major osteoporotic factors, you can see abaloparatide clearly 70% reduction versus placebo and a 55% reduction relative to teriparatide. And this is, again, the Kaplan-Meier with major osteoporotic fractures. You can see the curve separating very, very closely, very quickly. Now, adverse events, I'm going to point out a couple of points. Hypercalcemia occurs with a greater frequency with both of these drugs compared to placebo. There was more hypercalcemia in the teriparatide arm than there was in the abaloparatide arm. And also noteworthy are differences in palpitations and complaints of dizziness, with more complaints being in the abaloparatide arm than the teriparatide arm, but both of these were showing more effects, apparently, than placebo. And so this is an interesting sort of a vascular, vasoactive, maybe cardiovascular effect that we've seen with teriparatide, and we're seeing it maybe more with abaloparatide. And it speaks to other properties of PTH. PTH molecules are vasodilators. So if there isn't any compensation, PTH will drop the blood pressure. But PTH also, I say PTH, generic, all PTHs also, have an effect to stimulate heart rate, so they're chronotropes, and they stimulate the force of contraction. They're inotropes. We don't use PTH in this way, but we know that this is the case because we've done the studies where we've catheterized the coronary arteries of rats. If you've ever tried to do this, good luck. It's very, very difficult. But we did, and we were able to infuse directly PTHRP or PTH and show what I just told you. So the issue of hypotension, which is in the package insert for both drugs, dizziness, palpitations. Why do some patients get this as a complaint and others not? And most people don't, but some people do. And I think it's a matter of whether or not the patient can compensate for the vasodilatory effect by stimulating either heart rate or a force of contraction. Heart rate is not going to go up that much. You won't not be able to check and say, oh, the heart rate has gone up by 7 beats a minute. Probably does go up by 7 beats a minute within the first few hours, but you're not going to be able to know that. And the patients aren't aware unless they develop palpitations. So I think that why some of these people get dizziness, headaches, blood pressure may drop, may be a function of how well they compensate for the vasodilatory effects of these drugs. And because of this, I have certain rules about when I use these drugs. I do not use them before bed. I do not tell patients before you go to bed, inject yourself, because our older patients will typically get up a couple of hours after going to bed to go to the bathroom and, keel over maybe. So I don't like to give it before bed. Now, it's okay in the early evening. 7 o'clock, 8 o'clock at night would be okay. Or in the morning. So those are just sort of points I've picked up. The other thing is that we use these two PTHs. We inject in the abdomen. We do not use the thigh. We use the quadrants of the abdomen. We rotate. And why we use the abdomen and not the thigh is because the pharmacokinetics of pickup of drug are such that the abdomen being a richer source of the circulation, there's better circulation in the abdomen than the thigh, the drug will be picked up more quickly. So that's what we want. We want a spike in the blood, and you'll get that spike much better by using the abdomen and rotating the sites. Okay. Now, this is that 24-month study I told you about. And this has not yet been published, although it's going to be published. The paper has been revised and has been resubmitted. And this was the design, as I mentioned before. After 18 months, there was a 1 month of reconsent. And then after 1 month, there was a switch. Did Felicia talk to you about this study? No? Okay. Felicia was heavily involved in this study, as I was and a few others. So what we have is the 2-year experience with the placebo going to alendronate or abalo going to alendronate. There's no teriparatide switch. The teriparatide arm is gone. Felicia published the 6-month experience, and as I mentioned before, the 24-month experience is being considered. And I'm going to show you the 24-month experience because it's really the same as a 6-month experience. So again, 18 months of abaloparatide followed by 24 months, and the endpoints were radiographic vert fractures, non-vert fractures, clinical, all the usual, as well as BMD and safety. And then I won't go into the details of how they did the analysis, but they did it, as you would expect, with a fairly rigorous way of identifying vertebral fractures. The cohorts were basically the same, that is the active cohort and the active extend cohort. The 2 groups going to alendronate were well matched, fairly high incidence of prevalent vertebral fractures, and the like. So here are the data. This is now the 18 months data with regard to vertebral fractures. And now this is the extension of 24 months of alendronate. So the placebo group going to alendronate versus the abalo group going to alendronate, you still see that huge difference between the group that got abaloparatide initially, despite the fact that the placebo arm got 2 years of alendronate. Nevertheless, there's this lingering continued effect of abaloparatide that seems to continue to make a difference between the 2 arms. And then looking at this Kaplan-Meier, this is the first 6 months and then out to 24 months. You see that non-vertebral fracture reduction is also sustained. That is, the group that switches to alendronate from placebo is markedly different from the group that started with abaloparatide and went to alendronate. So vertebral fracture protection, non-vertebral fracture protection, and all clinical fractures, major osteoporotic fractures, are all significantly different when you compare these 2 arms. So let me compare the 2 PTHs. Abaloparatide does not require refrigeration. That happens to be a very important point. If your patients are like my patients, who are always traveling, going here, going there, and they have to find a fridge on the airplane, they have to find a fridge in the hotel, it's a drag. The instructions, though, with abaloparatide are that you should keep it refrigerated until you start using it. Seems strange. So once you start using abaloparatide, you don't have to put it back in the fridge. So the question is, well, why do you have to keep it in the fridge anyway? And the answer is pretty obvious. They don't know how long the drug is stable at room temperature. So until you start using it, keep it cold. And then once you start using it, you're going to use it up in 30 days. That's why it can be kept at room temperature for 30 days. They're both injectables. There's a transdermal being developed by the company for abaloparatide. The doses are different, 20 micrograms, 80 micrograms. The limited period is 2 years. And what the FDA says is use of either or both of these drugs for more than 2 years is not recommended. That's the language, not recommended. It doesn't say you can't or shan't. It says you are not recommended. Bear that in mind, because you're going to have situations, as I have, where I have several patients who are in desperate need of more anabolic therapy, and they've had 2 years of Forteo, and they cannot take DMAB, they cannot take a bisphosphonate, and you go down the list, and I'm done. I can't do it. So I have gotten approval to use Abaloparatide, making the argument that I've just made it, and being very respectful of the FDA's comment, not proscribing use for more than 2 years, but recommending that it not be used. The anabolic window. Yeah, you might buy into what I've been trying to tell you. Maybe wider with Abalo. Adverse event profile, less hypercalcemia maybe with Abalo, maybe more of the palpitations, dizziness. We don't have enough experience to really know how they are different, so I say similar. And then the osteosarcoma is the same. The drug causes osteosarcoma in rats. So if you are a rat, these drugs are very bad. All right. So the drug was approved about a year ago, and it's for postmenopausal women with osteoporosis at high risk for fracture, 2-year limit, black box warning. So let me touch on combination therapy. The discussion is going to be limited to use of Teriparatide as the osteoanabolic and use of Denosumab as the antiresorptive. There are many other combinations that have been studied. Alendronate and PTH I was involved in, raloxifene and Teriparatide I was involved in, zoledronic acid and Teriparatide, and most recently Denosumab and Teriparatide. Next Wednesday at the ACE, any of you going to ACE? You probably aren't allowed to leave your home base until you graduate after being here for 2 weeks. But next week in Boston at the ACE meeting, I'm giving how long is this talk? 40 minutes on combination therapy. But I'm going to limit myself today to just DMAB and Teriparatide. And this is work that has been spearheaded by Ben Leader at the Mass General. They published a number of papers. And you can see that the first set of this series of studies was a 2-year study called DATA, that's the name of the study, comparing Teriparatide alone, Denosumab alone, and combination. Okay? A small study, 30, 30, and 30. Why did Ben Leader think that this was a great combination? And I think you could probably answer it because I've already told you. Going back to our cartoon. Now instead of saying intermittent, I put in DMAB. And what's happening with DMAB and PTH is that what DMAB is doing is killing that catabolic pathway by blocking rank ligand. And if you buy into the idea that PTH needs rank ligand to be bad for bones, if you have DMAB aboard, PTH is going to have difficulty going down this pathway. So you get the advantage of Denosumab as an antiresorptive, and you get the advantage of PTH following this anti-sclerostin Wnt signaling pathway. That's kind of neat, isn't it? And if you wanted to dream up a combination, this is what I would use. If it weren't for the fact that I was the chairman of the Data and Safety Monitoring Board for Denosumab, I would have done this study. But I wasn't allowed because I was the chairman of the Data and Safety Monitoring Board. They said to me, can't do it, and so I didn't do it. But Ben did, and I'm going to show you the results. Randomized open label, change in bone density was the initial endpoint. These are the arms, and small number of subjects. So in the pink is Teriparatide. In the green is Denosumab. And in the blue is combination. And this is the change in bone density over 2 years. And you're getting up to like 14% in 2 years. Looking at the hip, a slower effect as you would expect with Teriparatide. Not a bad effect with Denosumab. and this is combination. That's pretty good. 6 to 7% improvement in 2 years. This is the radius. And what you're seeing is the effects of combination in blue, Denosumab in green, and Teriparatide in pink. Note a few things. One, the Denosumab group, or cohort, is showing a positive change in distal radius. And it's really the only drug we have where you can even show by itself a modest improvement in cortical bone by bone density. Combination doesn't do much more. Now this is the Teriparatide, and this is predictable. If you measure distal third radial bone density in people on Teriparatide, it'll go down. And some people will say, don't measure bone density of the distal arm because everyone's going to get upset. I do, because I like to see the distal third radius. But I don't get upset. Why don't I get upset? Because I know that these drugs, that is Teriparatide and Abaloparatide, despite what you're seeing, reduces non-vertebral fractures. So the bone density of the cortical bone in these cases is misleading because what's happening to microstructure is superseding the effect on bone density. You're getting more microarchitectural improvement than you're seeing this small decline in bone density. All right, so combination therapy is interesting, and if you look at these differences in the bone turnover markers, you see with these with combination and with Denosumab, you see a rapid drop in beta CTX within 3 months. But with P1NP and osteocalcin, there's a slower decline with the combination than with Denosumab. And of course, with the Teriparatide, you see increases. So Ben has argued that this is kind of causing another window because you're affecting bone resorption faster than you're affecting bone formation. This is actually similar to what you see with a pure antiresorptive. So he thinks that this is one of the mechanisms by which combination therapy seems to be better than monotherapy. And Ben has gone further. He's done microstructure with extreme CT, and I boxed the areas where there are advantages to combination therapy than with monotherapy in terms of total volumetric bone density, trabecular volumetric bone density, cortical volumetric bone density, cortical thickness, and it varies according to whether you're using the tibia or the radius. And then looking at finite element modeling on the extreme CT image, both together gives you better strength by FEA than by Teriparatide or Denosumab alone. So there is a lot to speak to the data study, and this is the combination of bone density differences, looking at Teriparatide DMAB combination. I've shown you the data. And then this is a comparison that Ben did with the zoledronic acid study and the PATH study, which were other combinations. But basically what he's saying is that you're seeing much greater changes in bone density with the combination of DMAB and Teriparatide than with zoledronic acid and Teriparatide, or the PATH study, which was alendronate and PTH-184. So in terms of, again, these are just different mechanisms and changes in bone density. You're getting a greater effect with this combination on bone density than the others. Now, this is where we are with combination therapy. Remember, we don't have a lot to go on with regard to true measures of efficacy. Yes, we have bone density and bone markers, and they are promising. We don't have any long-term data, and only the data I've just shown you with regard to microstructure by HRPQCT. That's all we have in terms of bone quality, and there are no fracture data. The other thing you should note, of course, is that you're using 2 drugs versus 1. It's more expensive. And using 2 drugs versus 1, there are going to be more side effects. So there are reasons not to use combination therapy, and rarely will I use combination therapy, even though the issue with DMAB and Teriparatide looks promising. So we're going to look at my crystal ball and talk about the future. And the future, in terms of therapy, we're going to focus on one drug. And this drug was developed as we began to learn about 2 very, very rare bone diseases. These are high bone mass diseases. One is called sclerosteosis, and the other is called Van Boeken's disease. They are primarily in the Dutch population, but I believe there's somebody in Brazil. I think there's a Brazilian, must be Dutch. There are Dutch in Brazil, you know. The northeast corner of Brazil was settled by the Dutch. So maybe that's the explanation. But this is basically a Dutch disease. Very, very rare. One of these diseases is off an island in South Africa. But these people have increased bone density throughout, the homozygous condition. They never break their bones. And it's because they have no sclerostin. Sclerostin is the inhibitor of the Wnt anabolic signaling pathway. And if you don't have sclerostin, that pathway doesn't have any brakes on it. It just makes more bone, and just continues to increase bone density. Now, it's not good to have too much bone. In fact, those people with sclerosteosis, the difference between sclerosteosis and Van Boeken's has to do with where in the sclerostin gene the mutation is. One is a point mutation in the coding region, and the other one is a cassette of genes that have been knocked out, sequences that have been knocked out. And sclerosteosis leads to big trouble because they basically sclerose their foramina, where the cranial nerves come out, and they get all kinds of neurological issues. But the heterozygous carriers don't seem to have any sequelae of the disease, but they too have higher bone density. They have higher markers of bone formation. They do have some sclerostin, but it's midway between none and what you would expect to be normal. So this was the clue that maybe an anti-sclerostin could be developed and would be an anabolic agent, like the disease. So let me give you a cartoon. This is the Wnt signaling pathway. We have receptors LRP4, LRP5, and 6. And Wnt engages these receptors in such a way that it prevents the breakdown of beta-catenin by GSK3 beta. And by preventing the breakdown of this intermediate pathway, beta-catenin gains entrance into the nucleus, where it transcribes anabolic functions. And if that was it, you'd have sclerosteosis. But for us, thank goodness, we have one of the brakes is sclerostin. There are other brakes, but this one we're going to talk about. And what sclerostin does is it interposes itself into this receptor system, does not allow Wnt as much access, and that allows beta-catenin to get catabolized in the cytoplasm and thus not gain as much access to the nucleus. So what sclerostin is doing is regulating the access of beta-catenin to the nucleus. And this is a dynamic situation. If you have a lot of sclerostin, you'll block a lot of this pathway. If you have less sclerostin, you'll let it go. So if you had an antibody against sclerostin, what would happen is that sclerostin would bind to the antibody and then free up or allow Wnt to get back or gain access to its system and get beta-catenin going. So it's neat. It's really neat. So by developing an anti-sclerostin, you could have an anabolic agent. Well, the anti-sclerostin antibody was studied in animals. This is a rat study. And different surfaces were shown. This is an overrectomized rat, and control, sham, or overrectomized plus the sclerostin antibody. And you can see the periosteal bone formation, endocortical bone phase just goes wild. And if you look at these three envelopes of the cortex, periosteal, endocortical, or intercortical, again, there's tremendous burst of activity. And the osteoblast surface versus bone surface, again, seems like it's a powerful anabolic. This is rats now. Remember, rats are different from humans. And interestingly, if you look at a bone resorption marker, osteoclast surface over bone surface, it reduces it. So it's stimulating bone formation, and it seems to be reducing bone resorption. And that was the clue that this drug may not be a pure osteoanabolic. And in terms of bone formation, this is work with the monkey showing that the surface of the two different bones that were studied are literally covered with evidence for bone formation. And this is some evidence that this drug, in its bone formation mode, may be taking advantage of bone modeling. Just like I mentioned before with the anabolics, the initial effect, this seems to be a rather profound effect on both the vertebrae and the tibia to build bone on quiescent surfaces. All right, there are two drugs. Actually, there's one drug. There were two drugs. The drug Bilezikian, you can forget. It's no longer being developed. But the drug we're going to talk about is Romosozumab. And if you say Romosozumab about 10 times in a row, you won't forget how to pronounce it. Pretty easy, Romosozumab. I say it at night 10 times, so I won't forget how to pronounce it. So here is a study. Felicia was the first author on this paper in the New England Journal a year and a half ago. 7,000 postmenopausal women, double-blind, placebo-controlled. The T-scores, you're getting used to what these studies are. The dosing was 210 milligrams of Romosozumab. That means 3 injections on a monthly basis, because you can only put Romosozumab in solution stably at 70 milligrams. So it's shot 1, shot 2, shot 3, or shot 1, shot 2, shot 3 for placebo. And then it's a 12-month study, followed by 12 months of Denosumab. Well, why did the company say, well, 1 year is enough? I didn't show you some of the phase 2 data, but it's a very powerful drug. And in 1 year, you're going to see tremendous increases in bone density. And I think one may say, be careful what you wish for. You know, can you have a drug that's too powerful? I don't know. But in any event, the company said 1 year, that's it, and then we'll go to DMAP. The endpoints were cumulative incidence of vert fractures, 12 and 24 months, and secondary endpoints were clinical fractures and non-verts. So the endpoints were at 12 months, which was Romosozumab alone, and then 24 months was Romo plus DMAP. So this is from Felicia's paper looking at bone density of the spine and the hip. You can see that after 12 months alone, there's a 13.3% gain in bone density at the lumbar spine, a 6.8% gain in the hip. After 24 months, now we're on DMAB, 18% lumbar spine, 8% in the hip. And this is the placebo group that gets crossed over to DMAB, and you can see what DMAB does. It does a good job. But you can see this tremendous effect of Romosozumab. This is femoral neck bone density, which is similar. Now, look at the changes in bone markers. This is P1NP, and this is CTX. P1NP jumps up to 150% of baseline, but by 1 year, it's actually crossed the baseline, and it's below baseline. So you have this huge pulse of bone formation, but it doesn't last. And then, of course, this is the DMAB arm where you're below baseline, as you'd expect. Now, this is CTX. CTX drops by 50% immediately. And then it makes a little bit of a recovery. This is actually reproducible. It always seems to happen. But it never gets to baseline, and then it goes down. And then when you get to the DMAB phase, it's even lower. So if you buy into this bone marker kinetics, you're not seeing a pure anabolic. You're seeing a transient anabolic that's converting itself very quickly to an antiresorptive. Very unexpected. All right, at 12 months, new vertebral fractures, 1.8% placebo, 0.5% Romosozumab, 73% reduction in relative risk. Clinical fractures, 2.5% versus 1%, 1.6%, again significant. And at 24 months, the data are new vertebral fractures, 2.5% versus 6.6%. Highly significant reductions in new vertebral fractures at 12 and 24 months, and clinical fractures. In terms of incidence of new vertebral, I've shown you this. This is the 24-month back. Now, clinical fractures are shown here, also significant. But if you look at first non-vertebral fracture at 12 months and at 24 months, there wasn't a significant difference. Now, that was surprising. Some people would say disappointing, because we want these drugs to be globally effective. And yeah, vertebral fractures. Yeah, clinical fractures. But what about non-vert fractures? We're not seeing a significant reduction. When you do a clinical trial on an international basis, you have planned to look for site-to-site heterogeneity in case your randomization wasn't perfect. Maybe there's a region that has a different demographics in terms of the baseline characteristics. And in fact, when they did the site-to-site heterogeneity test, it was detected. Then they had to do a post-hoc analysis to figure out where the heterogeneity was. And it turned out the heterogeneity was in Latin America. The countries, I think, were Brazil, Colombia, Ecuador, don't remember, it doesn't matter. If you looked at the Latin American countries alone, there was no difference whatsoever in terms of non-vertebral fractures. But if you took the rest of the world and excluded Latin America, you saw a significant reduction in non-vertebral fractures. And the FRAX, which is very interesting, this is all post hoc, the FRAX for major osteoporotic fracture, the Latin Americans had only an 8.7% risk versus the rest of the world that had a 17.6%. So for some reason, the randomization didn't work. The Latin American population was not at the same risk as was the rest of the world. And we know that populations that are at higher risk are more likely to show effective drug, or you're going to have to take longer to show effective drug. So that is perhaps an explanation for why there was a difference. There were a few injection site reactions. O&J was found twice, 12 months after Romo, somebody was wearing ill-fitting dentures. And 12 months after Romo, and 1 dose of DMAP following tooth extraction and subsequent osteomyelitis of the jaw. And there was 1 case of atypical fractures in someone who was having that prodromal thigh pain prior to enrollment. Now, Ken Sag just published a few months ago a study called ARCH. And this was a head-to-head comparison between Romosozumab and alendronate. After 12 months, both groups got alendronate. And the head-to-head was to ask, can Romo beat alendronate, a good drug, in terms of bone density and fracture endpoints? So, Romosozumab, after 36 months, but the 12-month difference is Romo versus alendronate, 13.7% versus 5%, 6.2% versus 2.8%. And then when the group was switched to alendronate, you saw a little bit more, but basically a big difference in terms of bone density at the hip and lumbar spine. And you've gotten very familiar with this. This burst in P1NP followed very quickly by a drop below baseline, while same pattern where you see almost a 50% drop in CTX, a little recovery, and then a further drop. And again, with the alendronate, you don't see that. You get a downturn in both bone turnover markers. And looking at fractures, you see that the group that got Romo then to alendronate, but this is 24-month data, versus the group that got alendronate throughout, there was about a 50% reduction in the relative risk. Again, other differences were clinical fractures. Romo beats alendronate by 27%. Non-vertebral fracture. Now, again, comparing Romo and alendronate was significantly different, and the hip fracture just barely missed significance. Now, adjudicated serious adverse events at 12 months. Cardiovascular events, an imbalance, 2.5% versus 1.9%, and cerebrovascular events, 0.8% versus 0.3%. What do you think?
I think on the paper they said 2 possible things, like maybe alendronate was a favorable medication for that route, or that we have sclerostin in the heart, and that in rats maybe have been shown that it can cause some cardiovascular effects.
Well, that's true. Those are 2 possibilities I mentioned when we were talking about bisphosphonates. Some evidence that suggests that bisphosphonates might have some cardioprotective effect. So maybe you're seeing this is a cardioprotective effect of alendronate and not a risk of Romo. And the issue about sclerostin being protective against vascular calcification, is it possible that an anti-sclerostin would enhance vascular calcification?
Sclerostin was found in the plaque, in the carotid.
Yeah.
If you analyze the plaque after surgery, there is the sclerostin.
I don't know. Has it been?
Yes. They evaluate the RNA in the plaque. There is this sclerostin.
So what's wrong with this study? Why can't we answer this question? Was this study designed beautifully? Head-to-head, drug companies hate to do head-to-heads because you have to have a big N to compare a drug that works versus a drug that might work better. So you have to add study subjects, much more expensive. Where's the placebo? Where's the placebo arm? Not there. So what would the placebo have shown? If alendronate was protecting, you would have a placebo, incidence of placebo related, whatever that will be, baseline, and then alendronate would have protected, and Romo would have been exactly the same as placebo. Or if Romo's making trouble, you'd have the baseline with placebo, and Romo would be worse, and alendronate wouldn't change. But you can't answer that question because there's no placebo.
But I remember we talked about this in our journal club, and all the other studies of bisphosphonates or other, there wasn't any cardioprotective effect in most of them.
Yeah, well, you're right. Some of the studies have not shown a cardioprotective effect, and some have. And it's, yes, to be fair, it's not clear at all. But you can't, I don't know that you can't say anything. You don't know. So what's happening is that the company has asked the group from the Brigham, the so-called TIMI group, to re-adjudicate all of this, getting data that they may not have captured from sites because you don't capture all data. So the idea is to try to get as much of a universe of adverse events as you can and see, in fact, whether this imbalance holds up. With the odanacatinib trial, which we aren't talking about because that drug died, the re-adjudication confirmed a similar type outcome, and the company basically said we're not going forward. I don't know what's going to happen when we learn about the adjudication, which will be in July. If it's held up, this imbalance is held up, I have no idea what the company's going to do. One option is to say, okay, we're out of here. Which would be too bad because it's really a good drug. Or they might say, no, this happened, but we have this explanation, that explanation, and there might be some kind of a cautionary note, black box warning, I don't know. But we have to wait. But it's a good example of how design can confound the analysis of a study if you haven't thought about it in that way. So in terms of mechanisms, we have the anti-remodeling agents, the rank ligand inhibitor, we have bisphosphonates that block bone resorption to a greater extent than bone formation. The CAT-K inhibitors we aren't talking about, but the idea was that they inhibited resorption to a greater extent than bone formation. We have the osteoanabolics that seem to stimulate bone formation, then they stimulate bone resorption. And then we have this mixed osteoanabolic and antiresorptive, the sclerostin inhibitors, that seem to have an initial burst of bone formation, then an antiresorptive, while they're, reducing bone formation, while they're behaving as antiresorptives from the beginning. So here is what we have in the United States now. I did mention strontium for people who know about strontium, but we don't have strontium. But these are the drugs that are available now. And I think if you looked at my crystal ball, what I would say is that we're not going to have strontium or calcitonin. One, because it's homeopathic, calcitonin. And two, sclerostin, I think there are big issues now with the side effects. And what we are going to have is an anti-sclerostin. That's my prediction. And I still have CAT-K in here because in Japan, a CAT-K inhibitor is being still studied. And I don't know where that's going, but it's possible that we'll have, at least Japan may have a CAT-K inhibitor. So we have learned a lot about bone through new insights in bone biology that have led very beautifully to the application therapeutically. Pathways that directly affect bone resorption or bone formation have given us those therapeutic options. And I think that we hopefully will even learn more and develop even more drugs down the road. So if you asked me from this sort of nice survey of where we are, I would say that we have a very hopeful scenario when we think about the therapeutic options to us down the road.